Morning everyone, today I'm here at Gentle Dentistry. We're filming our Friday 5 and today's Friday 5 is going to be 5 diagnostic tools used in dentistry, so I hope you enjoy. Hi, good day, my name is Dr. Urisa Yaklu and I'm one of the dentists here at Gentle Dentistry, and today I'm going to talk to you about a pulse sensitivity testing, what we call endo-ice, and what it is used for is to determine the health status of a tooth. It can determine if it's alive, if it could be saved with a filling, if it's on the way or dead or dying, or if it's a dead tooth. So basically what it is a cold test, right? It's a spray that comes like this, and it's tested on the tooth for a few seconds, and the patient elicits whether they get any sensation on the tooth. If the sensation lasts for 10 seconds or so, then we estimate that it's a normal tooth. If it is that it prolongs for a longer time, then it's indication to us that the tooth needs some sort of treatment in terms of a filling or maybe a root canal. If there's no response to the endo-ice test, that means the nerve in the tooth is dead, and therefore we need a root canal treatment, something a little bit more intense treatment for the tooth.
Hi, so I'm Dr. Ramlal. So I'm here today just to talk about briefly on intraoral cameras, right? So essentially an intraoral camera, it's a small digital camera that goes inside the mouth, and we're able to show patients what we're seeing. And it's a great tool to communicate with patients, demonstrate to them what's going on in the mouth. And it really makes a difference, and it really helps with patient acceptance and treatment and communicating. So for example, we have some pictures here. These are some old amalgam fillings that were done many years ago, and you could see some signs of leakage around them. So when you tell a patient a filling has to be changed, that's one thing, but when they could actually see the evidence, that's another thing. Right? Alright, so this is the intraoral camera here, and as you can see, it's very comfortable for the patients, very easily inserted into the oral cavity. Open wide and nice, and you can get all the way to the back.
Alright, so this is one of our patients. We did one of our scans for. The iTero scanner helps us to show the occlusion, the bite, where the patient has heavy contact. Where you see the red is where the patient is contacted heavily. So this patient here has heavy contacts to the back. And let me show you the top as well. So you'll see here where her contacts are very heavy. With this scanner, you can see a lot of things here. We can also show you a simulation of how your teeth will be if you choose to do Invisalign treatment. It gives you an overall view of the mouth.
Hi again, it's Dr. Yaklu. So today I'm also going to talk to you about another test that we do in the clinic to determine the health status of the tooth. It's what we call a tooth sleuth. What it is basically an indication test to let us know if you have a crack in the tooth or not that needs to be treated in some way. The tooth sleuth is a basic tool that we use. It's basically a bite stick that you bite on, and if when you bite on it and release and then you inflict some pain at that point, then we know the tooth has a crack that needs to be treated.
Hi, good morning everyone. I'm Dr. Basir. I'm working here at Gentle Dentistry, and I'm here to explain how we use the panoramic x-ray to help with diagnosis and treatment planning. The panoramic x-ray is a broad x-ray taken of the lower face, so we're able to visualize the lower and upper jaw and the associated structures within it. So if you could take a look at the panoramic with me, this is what a typical digital panoramic x-ray looks like. We get a very clear view of both the lower and upper jaw. In a typical assessment, we start from top to bottom. So we're able to see the jaw joint, what's the condition of it, if the person is grinding, if the person has any deformations of it. We're also able to see the sinus, which lays in our cheek and lays very close to the roots of our upper teeth. Then we move on to our other structures. We're able to see the teeth themselves, what are their conditions, if there's any infections. We're able to see how much bone is around the teeth as well, if there's any cavities, and if any teeth need to be extracted immediately. For our lower jaw, we're able to see an impacted wisdom here and how the roots are curved. We're also able to see the nerves within the jaw and how close these roots are associated to these nerves. So this is an overall image of what's going on in the patient's mouth. It's not the clearest of image, so sometimes we take more accurate x-rays to get a more zoomed in view. So here you're able to see some impacted wisdom teeth very close to the inferior alveolar nerve, which is the nerve that supplies the lower jaw. So we use this as an overall view to both diagnose and treatment plan for all our patients here. Thank you.
I'm Dr. Amcharita. So just to add a bit to what Dr. Basir would have said about PANS, I think PANS really give a vital contextual information to a patient's condition. Oftentimes dentists tend to treat a particular isolated issue, isolated problem that a patient comes in with, and really that is sometimes devoid of the whole context, which adds a lot of information to how to manage the treatment. For example, a patient may come in with a fractured filling or fractured tooth, and it's easy to take a periapical x-ray and just zone in on that issue, and you tend to that, and really you may do an excellent job at managing that particular issue, but really unless you take into consideration the whole context of the patient's mouth, you may be doing your patient a disservice, because you have to ask searching questions. Why did this tooth fracture? Why did the filling fracture? And oftentimes it goes right back to occlusion. And one of the best tools I find to assess a patient's overall occlusion is definitely a PAN, an OPG, right? And we use it routinely in private practice for that purpose. I mean, a PAN would give you a whole context of not just teeth, but teeth with bone in the oral apparatus, with soft tissue. Patients, of course, are not just a combination of teeth. They're made up of neuromusculature muscles that work together with the TMJ joint and informed by parafunctional issues at times. So, just to give a little bit of a context, we have a pan here and we just pull one up. It's not the best to demonstrate what we want to talk about, but you can just take an overview of this patient. Obviously missing some teeth, impacted wisdom, possibly some cavities, bone loss and so on. But really, you look at the TMJ joints, and so a few things are clear straight off the bat. There's an asymmetry in the joints, the left and the right side. And I'll go out on a limb to say that this patient would have some deviation on the mandible opening and closing. So, okay, so let me just, there's a definite and precise relationship or dynamic between the alignment of teeth, the muscles of mastication, primarily the masseters and the temporalis, that control the opening and closure of the jaw, and thirdly the ball and socket joint, the TMJ joint. So again, there's a definite, precise and reproducible relationship between the alignment of teeth, the muscles of mastications, and the TMJ joint. So it's a triad relationship. If anything goes wrong or goes out of whack, out of alignment with one of the three, it affects the other two. So if a patient loses teeth fairly early on in life and they get the drifting, shifting of teeth and so on, that in turn begins to offset the balance and the equilibrium in the bite. Left side versus right side teeth, we were told in school, should exist in harmony with the musculature and the joints. So if the bite is a shift in the bite, it provokes parafunctions into the muscles go into spasms, they go into hyperfunction over time, and that in turn, creates other issues in the oral apparatus. You get abfraction, recession, bone loss, gum loss, wear of teeth, fracturing of teeth, but you also get headaches and migraines and so on over a prolonged period of time of continuing parafunctional effects. Really long, the end game really informs this ball and socket joint, because protracted, prolonged parafunction, hyperfunction of these muscles has the effect of really compressing the head of the condyle into that fossa, articulating fossa, and there is a cartilage
disc that lubricates that motion basically. And over prolonged time, just think about the head, the circular head or semicircular head that fits into this socket like that. And over time, if you're clenching, you're going to be compressing the head of the condyle into that socket. And that in turn starts to create wear and tear on the internal of the socket and wear and tear on the head of the joint. And that causes what we call wear facets, which you can see, and you can actually see it here. A significant wear facet on the anterior of the head of the condyle of this joint. So it does paint a picture not just about a moment in time, but it does give a bit of a history about what has been happening overall in the patient's mouth over a protracted period of time. When you see changes to, say, TMJ joints, or you see gross bone loss generalized over a period of time, these are not things that happen very quickly. These are things that happen chronically over time, so it paints a longitudinal picture that the direction in which this patient's rehabilitation should take and what are the kinds of factors that should be taken into consideration.